So my presentation will focus on transplant patients, and I hope to be able to give you some guidance on the what the formula for prehab in transplant patients should look like. And I don't think I need to spend a lot of time on this slide. I think Dr. Kylie talked also a little bit about it, but I just want to say a few words. So prehabilitation is the process of optimizing tolerance of the patient for the upcoming stressor, which in transplantation usually is a major surgery. It's commonly used in an elective general surgery, as Dr. Kylie mentioned. It helps patients improve their physical function before the surgery, thus reducing post-operative recovery time and leading to quicker return to functional abilities. It usually involves a combination of aerobic and strength exercise and functional tests, as Dr. Carly mentioned as well. And it may also involve psychological and nutritional interventions, or it should involve. In my presentation today, you will see that the focus will be on the physical prehabilitation, because this is what most of the studies in transplantation have focused on. So what is the overall goal of prehabilitation in transplantation? So I don't think it's very different from the overall goal of prehab in other surgical patients. So we want to optimize quality of life, psychological well-being, and physical function before transplant. We also want to improve early post-transplant outcomes, such as hospital length of stay and functional independence at hospital discharge. So if they can go home earlier and more independent, that means that they will have a faster recovery. So what is the evidence? So my presentation will be focused on the evidence for prehabilitation in solid organ transplant candidates. So a master student working with me a couple of years ago, she conducted a systematic review looking at the effects of exercise interventions in this population. And just for you to understand, the type of studies that we included in this review, so you understand as I'm talking about the findings of this review. So we included original study of any design that included adults that were candidates of heart, lung, liver, kidney, and pancreas. And to be included in the systematic review, the majority of the study population should have been on a transplant waiting list or using a ventricular assist device as a bridge to transplantation. So of course, we can also borrow information from studies that looked at the effects of exercise in chronic lung or kidney or heart or liver disease. But we wanted to focus on studies that had specifically included transplant candidates. So it's hard to know sometimes, oops, we will just ask people to mute themselves. Hard to know how these populations, differ from each other, those who are considered just having end-stage disease or chronic disease versus those who are on the waiting list for transplant. But we wanted to have an idea of the feasibility of delivering these programs, the safety, and also if the studies had looked at post-transplant outcomes. So that's why we had this inclusion criteria. So before talking about the studies, the type of programs that they offered and the effectiveness, I just want to give you an idea of the quality of the studies. So you have this in mind as I'm presenting the findings of the systematic review. So 23 studies were included and 8 were RCTs, and 3 of them had high risk of bias. There was also no RCTs and pre-post studies, and these studies, and among those studies, none was classified as excellent, but the majority was classified as good. And we also use the consensus on exercise reporting template. It's a checklist to assess how well the exercise interventions are reported in these studies. And the total score of this search checklist, the total possible score is 19. And you see that we got lower scores for the studies that were included in this systematic review, meaning that the exercise programs were poorly reported. For example, many of them did not report the initial intensity for exercise or the progression of training of the exercise. In terms of acceptability and safety, we could see that there was a high acceptance rate, and it seems that the higher acceptance rate were in the studies that included lung and heart candidates. And from the 23 included articles, 15 reported no adverse events, which is very encouraging. However, adverse events were poorly defined in those studies. And we also need to be, we need to bear in mind that the patients had their risk stratified before starting the exercise intervention in this study. So it's a selective population. And also many of these studies were non-RCT, so we have selection bias there. Probably the patients were the ones who had previous experience with physical activity or exercise, and that were more willing to participate in exercise. So now I'm going to go through what we found in terms of, each of the studies, the type of training, a little bit of duration, and main findings by organ group. I decided to present this way because I know, as we saw in the beginning of the presentation, people usually, I think maybe the most common is that they work with one organ group. So we found, in terms of lung transplant candidates, we found 10 studies in total, 4 RCTs or non-RCTs, and 6 pre-post studies. This is this table shows the studies that were RCTs or non-RCTs. So this first study here was a very small study that offered physiotherapy program. This was very general, but it included education, aerobic, and strength exercise. And there's also this study here from 2012 that compared continuous versus interval training, and the mode of exercise was cycling. And again, this is all lung transplant candidates. These first 2 studies, they did not show any between group differences. This is, again, a very small study compared with no exercise, but this one compared 2 types of exercise. So there was improvement in exercise capacity in both groups, but there is no type of program or type of training that was superior than the other. The other 2 studies here, the Ockman from 2018 was offered a Nordic walking program, and the other group had no exercise. And the last study offered pulmonary rehabilitation with inspiratory muscle training versus pulmonary rehab only. And these 2 studies showed that there was improvement 6-minute walk distance, and this was shown in the group that did the Nordic walking, and also in the patients that participate in the pulmonary rehab plus the inspiratory muscle training. And also there is improvement in health-related quality of life in the patients that participated in the Nordic walking group. So these are the pre-post studies in lung transplant candidates. So in general, they offered aerobic and strength exercise. The duration of the program ranged from 4 to 12 weeks. And in general, they showed improvement 6-minute walk distance and health-related quality of life. It's important to note that among all these studies, only one looked at post-transplant outcomes. The study by Lee and colleagues was a study done retrospectively from the group from Toronto, and they showed that each 100 meters increase in 6-minute walk distance pre-transplant was associated with a 2.6 days decrease in median length of hospital stay. So after we conducted the systematic review, there were a couple of studies that were published in lung transplantation. So I just want to present them briefly here, and then I will continue to present the findings of the systematic review in the other organ groups. So this study was actually conducted by our group. So Nicolas Bourgeois is the physiotherapist from the lung transplant program here at the CHUM from the University of Montreal. And he's here in the call, so I'm sure he will be happy to answer any questions. And so in this study, we wanted to describe the changes in 6-minute walk distance in lung transplant candidates who had participated in a home-based exercise program. We also wanted to discern the relationship between changes in functional exercise capacity and post-transplant outcomes. And we included in this retrospective study 159 patients who had participated in this home-based exercise program that offered walking or cycling exercise as aerobic exercise and strength training. The median length of stay on the waiting list was quite long. It was about 699 days. And we showed, we showed in this study that the majority of the patients were able to either increase, you see that on the top of the, I can't seem to move my, okay, there. Yeah, either increase 6-minute walk distance or maintain their 6-minute walk distance during the time that they were on the waiting list and participate in the home-based program. We also tried to do some correlations with post-transplant outcomes. So we found a moderate correlation between last 6-minute walk distance prior to transplant and 6-minute walk distance post-transplant. And we found weak correlation between changes in 6-minute walk distance prior to transplant and time on mechanical ventilation. So, but when adjusted for covariates, there is no association. And importantly, we didn't find any safety issues in this study. So again, there's of course limitations. It's a retrospective study. We could not control for adherence and we could not include other outcome measures. But I think it's promising that many patients could either improve or maintain their functional capacity, and there's not so much problems with adverse events. Another study that came out last year, before our systematic review was published, was the study by the group from Toronto. They looked at the response of the short physical performance battery to pre-habilitation, and they presented their findings by group of patients who were either frail and pre-frail, or that were not frail. And here you can see that they found an improvement in SPPB in the group that were frail or pre-frail, but not in the group that was not frail. So I think this goes in line with Dr. Carly was saying about who is benefiting for pre-habilitation. Their program was about 6 weeks, and they also found that the SPPB in the frail and pre-frail patients that was done closest to the time of transplant was associated with a lower 6-minute walk distance, but not hospital length of stay or gait use 3 months post-transplant. So we started having a little bit more information about post-transplant outcomes as well. So back to the systematic review, and now looking at heart transplantation, we found 7 studies in total, 5 RCTs or no RCTs and 2 pre-post studies. In general, these studies included patients who were on VAD as bridge to transplant. The majority of the studies were offered or were conducted in an inpatient setting. They offered aerobic and strength exercise, and they lasted between 8 to 12 weeks. And 3 studies showed improvement in VO2 peak. Unfortunately, these analyses were all within group analysis, and there's no improvement in functional exercise capacity, anxiety, or depression, or quality of life in any of these studies. Some of them included those kind of outcomes. The 2 pre-post studies in heart transplantation offered, one offered MIT, the inspiratory muscle training, and the other one offered upper body strength exercise only. This is the duration of the program, and the first study improved. They showed that improved maximum inspiratory pressure and maximal expiratory pressure. And in the second study, there is no difference in any of the outcomes. They looked at maximal voluntary contraction and hand grip strength. But again, these were very, very small studies with 8 or 9.
Resistência, aí você balança pouco. É, uma balançadinha, não tô dizendo que, mas tem uma balançada aqui.
Okay, may I continue? Okay, so now liver transplantation. So only 4 studies in total was, are you still hearing me well? Sorry.
Yes, we are.
Okay, okay. Yeah, so in liver transplantation, only 4 studies were found, 2 RCTs and 2 pre-post. So these were the 2 RCTs. It seems that it's the same interventions from the same group. I think here was a pilot study. Here they have more patients. They offered a strength exercise, but basically abdominal muscles, focusing on abdominal muscles, breathing exercise, inspiratory muscle training, and diaphragmatic breathing. And they had a control group who received, they received no exercise. The duration was 12 weeks. This first study here, they showed was within group analysis. They showed improved maximal inspiratory pressure and maximal expiratory pressure. In the second study with more patients, there is no difference in any of the outcomes. Liver transplantation, again, sorry, still, but these were the pre-post studies. This first study offered aerobic and strength exercise for 12 weeks, and they showed improvement in 6-minute walk distance and VO2 muscle strength. This other study here, more recent, offered functional endurance exercise, frog, for example, frog squats, lunge, bear crawl, etc., with small rest intervals. So we can get a little bit of an aerobic component there. Also, it was offered for 12 weeks. They showed improvement in incremental shuttle walk test, but none of the studies actually showed improvement in depression, anxiety, or health-related quality of life. Finally, kidney, it was the organ group that there were less studies about, so one RCT and one non-RCT. The RCT included or offered yoga plus mindfulness-based stress reduction, and the other group received a telephone support group with no exercise. And the duration was about 8 weeks. There is no improvements in anxiety in either of the groups. There is an improvement in the mental health domain at 6-month follow-up in the mindfulness group, but this study did not include any other outcome that was related to physical function. The study by McDam and DeMarco from 2019, they offered aerobic, strength, stretching, and balance exercise. They also had a historical control, and patients exercised for about 76 sessions, and they showed improvements in physical activity at 12 months. Also patients who participate in their program had reduced length of stay post-transplant. So you can see that there is very limited evidence, and I can actually mention all these studies during this presentation. So it's, of course, we need to do much more, include more specifically transplant candidates in these studies, but we have some important information as well. So I just wanted to, before concluding and making some recommendations, I wanted to mention about the second study that my master's student worked on. Her master thesis was consisted of the systematic review that I presented to you today, and also she conducted a pilot study. It was a pre-post study that offered a home-based exercise program for kidney transplant candidates. And because there were so few studies that we found in the systematic review, I thought it would be interesting to present some of this data. Although you will see that the study is very, very small and unfortunately was impacted by the pandemic, but I think we got some lessons learned and some preliminary data that it might be interesting to share. So this program was a 12-week program. We offered a walking program and leg, arm, body weight exercise, basically push-ups and squats in patients who were in kidney transplant candidates who were frail. So we focused on feasibility, safety, and effectiveness of this program. And again, I already said it was affected by the pandemic. As in many other centers, research activities here at the MUHC were interrupted on March 16. But at that time, she had able to recruit and to do all the initial assessments, and the patients were able to start doing the program at home. The problem was with the post-intervention assessment. We needed to pivot to remote assessment, and there is a lot of missing data, especially for the 6-minute walk test and the hand grip strength test. So just to say that, you will see that in the end we have data from 3 patients, but it's very encouraging. So I wanted to show you today. In terms of lessons learned or preliminary data, so it was encouraging that we did not find any barriers during the recruitment process. She recruited patients during 2 months. Eligibility rate was quite high, 75%. Refusal rate also very low, was 15% when patients were approached one-on-one. When we tried to approach them in a group setting during the educational sessions that they had about transplant, that was a little bit more complicated to approach them, but when it was one-on-one, it worked really well. So in the end, 11 patients consented to participate, but only completed the pre-intervention assessment. This is an important information about feasibility. 2 patients underwent transplantation during the study period, so it was a dropout. And in the end, we had the pre and post intervention data on only 3 patients. But again, what we saw, it was quite encouraging. So I want to share that with you. I know this is a very busy table, but I just want to go through this preliminary findings of this pilot work. We will continue to do this study. And now that we are able to go back to some research activities. But in terms of frailty, whoops. Something came out of it. 2 out of the 3 patients improved their frailty status. So one had pre-frail, they moved to non-frail, the other one was frail and moved to non-frail. We also measured lower extremity function by the SPPB. 2 participants maintained their score of 12 and 1 participant improved from 11 to 12. The total possible score for SPPB, as you may know, is 12. So it feels like we had a ceiling effect here in our patients, but this seems to be atypical in other studies, larger studies. At least 50% of the patients have impairments in SPPB. So we believe that if we had included more patients, we would have seen more impairments. But anyway, it was interesting to see that some were able to maintain or even improved. We also assessed health-related quality of life, and in the domains of symptom, effects, and burden of kidney disease and mental health, there's they either maintained or they improved those domains. Interestingly, there's no improvement in physical health domain in any of the 3 participants. 6-minute walk test, as I said, we were not able to conduct because we had to do the rest of the assessment remotely. But we were able to get some pre-intervention assessment data. We noticed that the percentage of the normative value ranged from 28% to 108%, but only 1 had a score higher than the normative value. So I think compared to the SPPB in this group of patients, the 6-minute walk test seemed to be perhaps a better test to use, or to at least to be able to see an improvement after the intervention, but we were not able to do it, unfortunately. We asked the patients about acceptability of the home-based prehab program. So I'm just going to give you an example of the first question here. And I can say that all 8 participants who initiated the program unanimously stated that performing the prehabilitation program at home was a good idea, pleasing, safe, easy, helpful, and simple. So that was very encouraging as well. So now I think just putting all together and looking at the gaps and the limitations, as you could see, there's a small number of studies that we can actually count in our hands and put all them in the slides in a 20-minute presentation. And most of them included small sample size. The majority of the studies offered hospital-based interventions. Not that this is a limitation itself, but considering that there are few transplant programs, around the world, I would say, and patients don't necessarily live in the city where the transplant centers are, I think we need to start thinking about more home-based programs or virtual programs for these patients. I know some programs, they ask the patients to move closer to the centers to do the hospital base, but this may not be ideal for many patients and families. Most of the studies offered, as you could see, short period of training. So few offered exercise during the entire waiting list period. So this might be because they were research studies. And perhaps I think there are many clinicians here, and you can tell us later, your clinical program might offer the prehabilitation program during the entire wait list, the period of the waiting list. But for research, it might be a bit complicated to offer long programs because of funding limitations and so on. The majority of the studies did not examine post-transplant outcomes. So then it comes to the questions, do we really know the impact of prehabilitation? So we are doing exercise before, but how is it impacting on their recovery post-transplant? So very few, I think, our retrospective study, the study from Toronto that included some post-transplant outcomes, and the studies were retrospective anyway. So what is the formula for prehabilitation in transplantation? I don't know if I can give you a specific formula because of the limitations in the evidence, but as Sunita mentioned, we put together position statements a couple of years ago on exercise and solid organ transplant candidates. And we made some recommendations there based on the best available evidence and based on expert opinion. And this is what we recommended, or what we wrote there. So I think we agreed that prehabilitation is safe. Of course, it's for a selective population, or we need to think about who is going to benefit more. We need to think about the risks. But in general, I think it's a safe intervention or treatment. It seems that aerobic exercise or combined aerobic and resistance exercise is the way to go. Unfortunately, there is insufficient evidence for the optimal duration to obtain the benefits. Ideally, during the entire wait-list period, we don't know. I think we will need to study more. Perhaps we could do a more kind of like an induction phase in the beginning and then a maintenance phase at the end until the date of the transplant, which usually is not known. We recommended that this prehabilitation program should be supervised or have some kind of supervision. There's some, emerging evidence on home-based programs, but some supervision, we believe that it's important for these patients. And these two other topics here were not really in the position statement, but I think after reviewing publishing this systematic review, I realized that there is potential role for inspiratory muscle training, and this is not well explored. And of course, as Dr. Carly mentioned, nutrition and psychological support is very important as well. And those studies that we included in a systematic review did not include those components. In terms of future research directions, of course, after reviewing the literature, and you may have noticed it as well, so there's a need for larger and well-conducted trials that specifically include transplant candidates. We need to think about, or design this study to think about beyond functional exercise and muscle strength, but we need to also think about other types of outcomes on the wait list period. For example, healthcare utilization, mortality, frailty, and also post-transplant outcomes. It would be nice to know what is the best setting, mode of delivery, how is the role for home-based and virtual programs. So this is what I had to tell you today. I just wanted to acknowledge and thank all my team members and collaborators and the funding agencies that have funded our studies. Thank you.
Great. Thank you, Dr.